Good morning, friends. On behalf of Bayer, I welcome you all to this Bayer DME symposium. This is going to be a very special one because this is regarding focusing mainly on the 8 milligram dose, which perhaps for our country is going to be sort of introducing a molecule which we have not used as yet. And I welcome you all to New Delhi and India. Please just take care of some of these things. Well, friends, I myself come from northern part of country called Chandigarh, and that is where I am based. And these are my disclosures. Basically, the symposium aims to outline the rationale for developing an innovative formulation of Aflibercept. And it will highlight how Aflibercept 8 milligram aims to shift the curve for eligible patients group with diabetic macular edema based on 3 years of the trial data and the clinical experience from across the globe. And we'll also discuss how the sustained disease control achievable with the 8 milligram has potential to, or it may address another very important issue, which in fact all of us in this field in retina need, is a fulfilling the unmet need. I'm really happy to have here all the big stalwarts from across the globe here. I have personally known some of them for a long time. Professor Michael Stewart, who has been visiting our country for quite some time, including a couple of times he visited even Chandigarh. And Professor Richard Gale, who's from medical school in UK, and he has just flown in, very kind of a tight schedule and going back. And of course, my friend Tim Lai, again, whom I have known for a very long time from Hong Kong. And also we have Dr. Shobha with us. All of us, we know her. She's been coming and educating us for a long time here. The agenda of the meeting is Aflibercept in abundance. I think we'll go with this subsequently, and we'll address each and every issue the way it is going to be. So first there'll be talk by Michael Stewart, Richard Gale, and of course some of the experiences, the clinical experience, the cases, and then we'll have a little panel where some of the questions can also come from the audience if there's a time, and we'll have a little summary in the end from me. So with this, I hand over for the first talk to Professor Michael Stewart, who's going to talk about the Aflibercept in abundance, sustained disease control with 8 milligram.
So good morning. Thank you, Dr. Dogra, and also thank you to Bayer Asia Pacific team for inviting me. It's certainly my pleasure to talk in this diabetic macular edema symposium. And let's see if I can get this to work here, my financial disclosures. And really, despite the fact that we and our patients have really been the recipients of excellent advances in anti-angiogenesis development over really now the past 20 years, we still have significant unmet needs with respect to the treatment of patients with diabetic macular edema. We've been very fortunate over the last, in the United States, 13 years, that we have Aflibercept 2 milligrams, which has really become the agent of choice in many of the countries throughout the world. And we've not only seen great results with respect to DME treatment from Vivid and Vista, but we also have real-world clinical trials that have shown it to be effective and safe. And here are some treat and extend trials coming out of the Asia Pacific region from Taiwan, South Korea, and Japan, all of which show excellent disease control, improvement in visual acuity, and good extendability over the course of 1 and even up to 2 years. And we've seen that Aflibercept 2 milligrams has really had an excellent safety profile when used around the world, with currently more than 84 million doses given since its launch. Nevertheless, we are facing an epidemic in diabetic macular edema, which parallels the epidemic we're seeing in the increase in number of patients with diabetes. And so we're challenged because treating patients effectively and having them maintain their compliance is going to be more difficult, especially when we keep in mind that the average diabetic sees over 25 medical examinations per year. We are one component of that, and trying to make sure that patients comply with their ocular treatment is going to get ever more difficult as treatment for diabetic care gets more sophisticated. Groups from around the world almost unanimously agree that reducing patients' treatment burden is probably the single greatest unmet need. This data from your retina shows that over time, we've become even more cognizant of that, with a majority of physicians actually saying that we need to reduce the treatment burden. And the burden is not just on us and our practices and offices, but on the patient having to come in repeatedly, on the patient's caregivers, as they have to take time off work. And in fact, if you look at data out of the US, about half of the money spent on diabetes care is actually not direct care. It's actually the indirect costs associated with getting patients to and from clinic visits, lost time at work, and taking care of patients who have diabetes-related disabilities. And so really what we need is greater and longer-lasting disease control through sustained disease control. So how can we do that? How can we improve current anti-VEGFs to achieve sustained disease control? Well, if you put yourself in the mind of a drug developer, there are several factors you're looking at as to try to create a new drug or improve a therapy that's already been established. And here are 5 of the major pharmacokinetic contributors to how well drugs work. Binding affinity and potency on the left really talk about how well the drug binds to its target ligands and then inhibits either free ligand within the space or VEGF-mediated processes. On the right-hand side, you have molecular targets, and then lower right is molar dose and ocular clearance, which we'll talk about in a little bit more detail. Aflibercept has really had a very attractive pharmacokinetic profile with high reported potency, the highest binding affinity of any of the anti-VEGF-A drugs, and the most diverse range of molecular targets, not only VEGF-A isoforms, but also placental growth factor, VEGF-B, and galectin-1. And we know that the key driver to angiogenesis problems is really VEGF-A binding through VEGF receptor 2. That then dimerizes the receptors and increases all of those downstream effects that we see with angiogenesis. But working in parallel with that is receptor 1. And though VEGF-A binds to receptor 1, so does placental growth factor. And so we think that may contribute in some way to the angiogenesis effects that we see. And only by binding placental growth factor do we really inhibit all of the VEGF-mediated angiogenic processes, namely inflammation, neovascularization, and breakdown of the blood-retinal barrier, which of course contributes to macular edema. So how can we improve drugs? By binding to new targets, by creating drugs with different pharmacokinetic profiles, or if you will, by creating a new drug that's based on an excellent safety profile and gives us new pharmacokinetic characteristics. So if we go back to Aflibercept, we have this 13-year history of excellent sustained disease control with a beautiful safety profile. How do we make it better? Well, we changed the drug. And in doing so, we increased the molar dose. And that's what Aflibercept 8 milligrams was designed for, was quadrupling the dose, theoretically extends its durability within the eye by about 2 half-lives, or anywhere from as little as 14 to up to about 22 days, depending on what half-life we use. But what we found, what was interesting, was not only was the molar dose increased durability, but a little bit unexpectedly and quite fortuitously, we found that the clearance of the drug was actually decreased by 34%. So not only do you get extended durability by adding more drug, but the drug stays in the eye longer and leaves the eye much more slowly. And we found that from pharmacokinetic modeling that we think that it has the ability to inhibit VEGF by anywhere from 6 to 8.9 weeks longer than we see with the 2 milligram drug. And so we have to ask the question now, how might this help our patients? Well, most patients are treated on a durability basis according to sort of this bimodal distribution. And so can we help the patients on the left who require frequent injections by shifting the curve to the right, decreasing the number of patients that require injections every 4, 6, or 8 weeks? And we know from clinical experience we're not going to get those patients generally out to 20 or 24. But if we can increase their durability from 6 to 10 weeks, that's a major win, both from our perspective as well as the perspective of the patients. And then secondly, how about those patients that we're treating on 12 to 16 weeks, which historically we've thought were actually quite successful? Well, now with new durability, we can extend them out to 20 and 24 weeks. That's part of what we'll talk about today with respect to the PHOTON trial and the number of patients that actually get durability at the 20 and 24 week marks at the end of 2 and now with our 3-year data. And so really what we're looking at is sustained disease control by taking an existing industry-leading drug and making it better by creating the 8 milligram dose, and doing that by keeping in mind that we're doing it with a very comparable and excellent safety profile.
For giving exactly what we want to know about how the drug is acting and how we get all the things which subsequently would be discussed. And now I call upon Dr. Richard Gale. He's going to talk to us on shifting the curve with Aflibercept 8 milligram in diabetic macular edema, 156 weeks data from the PHOTON trial.
Thank you very much, dear Chair, dear Conference, and dear Bayer. Thank you very much for the opportunity to continue on the discussion from Michael's excellent talk titled Shifting the Curve with Aflibercept 8 milligrams, with a particular focus on the 156-week data from the PHOTON study. Please note my financial disclosures. So I'm going to spend a little bit of time talking about the key aspects of the PHOTON study, which was designed to explore how 8 milligrams could gain better outcomes from a higher molar dose of Aflibercept. And some key aspects here that this was a randomized controlled trial, multi-center, phase 2-3, in both previously treated and treatment-naive patients with diabetic macular edema. They were randomized 1 to 2 to 1 in the following groups. And this is a really important aspect. So after 5 initial 2 milligram monthly doses, the first arm continued on with 8 weekly doses. The 8Q12 doses arm had 3 monthly doses and then continued on at 12 weekly. And the third arm had 3 monthly 8 milligram doses and then continued on at 8 weekly. And the concept was the primary endpoint was non-inferiority at week 48. The end of study was week 96. But this talk is going to focus on the extension study through week 156, the optional extension study. So let's just recap how the study got on out to week 96. So through year 2, PHOTON achieved good, lasting visual gains with rapid and resilient fluid control with extended treatment intervals. And what I'd like you to notice on the right-hand side in particular is the reduced burden, which is very important for our patients and healthcare systems, as Michael mentioned earlier, with 7.8 mean injections at year 2 for the 8Q16 group compared to 13.8 with the 2Q8 group, and an even lower number of injections in the second year. Now I'm going to explain details about the extension study. So the concept is that all individuals who entered this were moved on to 8 milligrams. Those in the 2 milligram group were switched to 8Q12, that's 12 weekly initially. And the 8 milligram group was switched to a regimen of their last assigned treatment interval. So just to be very clear, individuals were seen on a monthly basis on 3 occasions after the switch, and then quarterly assessments were made. There was the ability both to reduce or extend the treatment criteria in the so-called EDRM criteria. So for shortening, individuals would have a greater than 10-letter loss and an increase in greater than 50 microns of central retinal thickness, or greater than 15-letter loss. And to reduce the interval, individuals would have had a less than 5-letter loss with a really quite dry central thickness. That's less than 300 or 320 on the spectralis, compared with the new reference point. So let's see how they got on. So we can see here that there was lasting vision gains, which is sustained and meaningful and extended through year 3. So we can see week 48, the improvement in visual acuity with the 2Q8 and the 8 milligram groups. This was sustained out to week 96. And take particular attention now of the extension, where these gains were maintained through 156 weeks at around about 8 letters in both arms. So the mean number of injections was reduced, particularly in that 3rd year, with the 8 milligrams requiring 3.3 injections on average. Let's have a look at the central retinal thickness now. So this is the 8 milligram group, and we can see, as anticipated, a rapid reduction in central retinal thickness, sustained out to year 1, and likewise out to week 96. And furthermore, this continued with an improvement numerically out to week 156. Now let's have a look at the 2 milligram group, and this is really quite interesting to spend a bit of time on. So typically we see the reduction in central retinal thickness and this seesawing effect that we've been used to over time, with a general trend to increasing the central retinal thickness. Now concentrate on what happens when the first 8 milligram is given after week 96. We see a further reduction in central retinal thickness. In fact, the largest reduction following the initiation of around 54 microns, and then a slower return to the increase in central retinal thickness. And that to me speaks to increased power and durability of the 8 milligram molecule. And this central retinal thickness was maintained out to week 156. And what does this mean? It means for our patients that there were extended treatment intervals, such that the last assigned treatment interval for the 8 milligram group was around about 16 weeks or more in 7 out of 10 individuals, and in fact 20 weeks or more in around half of individuals. In the 2 to 8 milligram switch group, around 80%, 8 out of 10, achieved intervals of 12 weeks or more as assigned at week 156. Now, it's really important for us to concentrate on the safety profile of the molecule and the dosage as well. And I was pleased to communicate here that the safety profile of the Aflibercept 8 milligrams was comparable to that of the 2 milligrams through year 3. It's really quite important that we have a focus on intraocular inflammation. And there were low amounts, a few percent, which were equally balanced across the group. Furthermore, with a higher dose, it's important to study the APTC events, for example, heart attacks and strokes, and we see that they were balanced and comparable to that of Aflibercept 2 milligrams through year 3. So in summary, the photon extension had 3 key findings. It produced lasting vision gains with 3 initial monthly doses and extension thereafterwards. We reviewed a rapid and resilient fluid control through week 156. And very importantly for our patients and healthcare systems, on the right-hand side are the extended treatment intervals. 7 out of 10 patients had a last assigned treatment dose of greater or equal to the 16 weeks, about half greater than equal to 20 weeks, and around 8 out of 10 patients greater or equal to 12 weeks at year 3. I'd like to thank you for your attention.
Thank you, Dr. Richard, for giving us what, in fact, everybody, all of us are looking forward to what the photon trial and the extension has to kind of what you have, the way you have summarized the whole thing. I think it clearly shows the differences between 2 milligram and 8 milligram dose. So we go on to now the basically, I think now it's going to be the clinical experiences. I think this is going to be more interesting, and we'll have perhaps that's where we may generate more discussion also with such a real world data.
Dear Chair, thank you very much. So we're now moving on to from bench to bedside, reflecting our clinical experience with Aflibercept 8 milligrams in diabetic macular edema. And myself, Michael, and Tim will be sharing some cases and discussing them. Please note our financial disclosures. So I was really delighted that we're having a cricket theme here, and the cricket theme is that I'm going to be the opening batsman, perhaps Sachin Tendulkar, who knows? Michael is going to be the all-rounder, and Tim is going to be the finisher. And we are going to discuss cases, and we'll let you decide which one is the winner out of the case. Of course, this is not a competition. So, I'm going to talk about a case which I think underlines the importance of the 8 milligram molecule in the ability to gain anatomical control when switching to that therapy from other therapies. And I'm going to discuss a 63-year-old male with mild non-proliferative diabetic macular edema who was previously treated with diabetic macula for 4 years. A very tricky case to treat that I'm sure we're all familiar. So these are the images on the right-hand side, the Optos images of an individual with mild non-proliferative diabetic retinopathy. In the past, the reference central retinal thickness stability was 293 and 259 microns respectively in the left and right eye. And this individual had multiple treatments, all with very good agents, but all perhaps not performing as well as we would like. So individually, the individual had fluocinolone acetate, had Aflibercept 2 milligrams, and dexamethasone implants, as well as faricimab. The dexamethasone implant, unfortunately, had a relapse of the diabetic macular edema at 13 weeks, so the durability wasn't as we would expect. The fluocinolone acetate implant, unfortunately, gave an insufficient anatomical and visual result. Now, all medications, as mentioned, can cause intraocular inflammation, and there was mild inflammation due to faricimab, and our particular policy, if that occurs, is to move away from that medication afterwards. Of note, there was past cataract uveitis. So, the individual was on 4 weekly 2 milligrams, and these are the central retinal thickness maps and cross-sectional OCTs, and you can see residual central retinal thickness with a central retinal thickness of 462 on the left and 329 on the right. So I'm going to ask you, what would you do next? Would you continue Aflibercept 2 milligrams, start Aflibercept 8 milligrams, perhaps an alternative therapy such as macular laser, or other? Well, as 8 milligrams, an alternative, an additional therapy and an armamentarium became available, we started this medication. And this is the result after a single injection. So we see a reduction of the central retinal thickness to 323 microns with a gain in visual acuity. And I feel this reflects what we were seeing in the photon study. Remember, the photon study had previously treated patients. So I hope you're going to vote as this as the most successful case. Thank you very much.
great case, Richard. I think we may have discussion a little later once we are going ahead with other cases. So,
So
yes,
thank you.
Michael, yes.
So thank you. I have to lodge a protest because here I am facing a bunch of excellent physicians coming from countries that play cricket. And though I was competitive with a bat, baseball doesn't translate well into the cricket forum. So I have two cases, and you'll see that mine are just a little bit different from what Richard has presented and what Timothy has presented. And we're each focusing on sort of different qualities that we see with aflibercept 8 milligrams. And mine focuses more on durability of patients that are already reasonable responders. The first is a 52-year-old male. This is a physician's assistant. So he's very knowledgeable regarding this disease. And despite the fact that he has an A1C of 7.5, he's generally a very compliant patient. Furthermore, his wife is the former chairman of our emergency room department. So he recognizes that if he doesn't do things properly, he's going to go home and he's going to get a lot of grief from his wife. So for that reason, he really comes across as a very, very good patient. At baseline, when I first saw him, you can see centrally here is 2050 with significant intraretinal edema as well as subretinal fluid. And it started him on aflibercept 2 milligrams, and he responded beautifully. He dried up very quickly at 4 weeks. I extended him out. We go to 6 weeks. He's doing really well. And then every time he went to 7 weeks, and this happened 3 times over the course of several years, his fluid came back. And when the fluid came back, the visual acuity began to drop. And these were sometimes planned, but sometimes because of my travel or his inability to get to the clinic. But we figured out that 6 weeks did very well. So we treated him at 4 to 6 week intervals because that's what seemed to work with respect to his treatment and our schedules. Finally, I had 8 milligrams available, and I said, well, maybe we can try something just a little bit different here, and maybe we can extend you beyond that 6-week ceiling that we seem to have hit. And so I decided on a strategy that I would never use for the majority of my patients, but I used for him. I said, we're going to give you 1 injection, and then I'm going to bring you back in 6 weeks and see what happens. And you can see at 6 weeks, he's 20/20. Not surprisingly, looks good. I said, come back next week. Now we have 7. Next week, 8, 9, and finally at 10 weeks, he begins to develop a little bit of recurrent edema, and his vision begins to drop slightly. So I figured out 9 weeks after the first aflibercept 8 milligram injection is probably where he goes, and so I continue him on 9-week intervals with aflibercept 8 milligrams, and we've done that very nicely now. So this is one of those we talked about shifting the curve earlier on in my talk, where I said those patients who require frequent injections can be extended. If they're doing well, they can be extended. He's not going to get to 24 weeks, but he does get 50% increase in the interval after single injections. So he's done very well, and we're both very happy now that he comes in once every 9 weeks. The second is a 62-year-old woman who presented to me initially for a second opinion for macular edema. And you can see here she's 20/50, significant edema. And this happened several years ago, and I'm a strong believer in protocol T, so I began her on aflibercept 2 milligrams. 5 monthly injections. She's improved to 20/30, 3/4 of the way down the page. And now I go to every 8 weeks, and she still continues to improve visual acuity and remains quite dry, does very well. I said, you're doing really well at 8 weeks, maybe we can go a little bit further. So we go to 10 weeks, and her fluid comes back, and her vision begins to drop. I decided to drop her to 9 weeks, and she did very well. Continued along, treating her every 8 to 9 weeks, and then eventually I said, let's try it again. We go to 11 weeks, and her fluid comes back again. 9 weeks, and once again, she's under control. So again, we've reached this very consistent top-end interval of 9 weeks that this patient gets on aflibercept 2 milligrams. I think most of us would think that's a pretty good treatment. That's a success. But nevertheless, when we look at sustained disease control and extendability with decreased number of injections, we'd love to get better. So finally I get 8 milligrams, and I say, let's go ahead and switch you to 8 milligrams. So now she comes back at 11 weeks, does well, I inject her. Now I'm getting a little bit bolder, because now I go to 3-week adjustment. Come back at 14, then I get bolder yet, and I go to 4-week adjustment at 18, and she's doing well. She's completely dry. She's 20/30 at 18 weeks. The next interval will be at 22 weeks going forward. So I've actually doubled her interval, which is a little bit more than I expect. My rule of thumb with 8 milligrams compared to successful treatment with other drugs is increasing by about 50%. She's actually done better than that, and now we're out at 4.5 months for her treatment. So here you can see our summary that patients doing well, albeit with short intervals, certainly can be extended when switching to 8 milligrams. There is a limit, but we can find that limit quite easily and maintain the same visual acuity that we get on the shorter intervals. Thank you.
Thank you, Mike, for showing great cases and especially switching from 2 to 8 milligram and the advantage which you have very clearly shown in your cases. Yes, we go on to the Tim Ply's case.
Well, thank you, Bayer, for inviting me to join this session and also to talk about cricket. So I'm glad to finish because I'm not very good with the bat, but I did my med school in Australia, so I grew up watching Shane Warne, so I learned a lot of spin bowling from him. So let's talk about Aflibercept now instead of cricket. So this patient actually switched to Aflibercept 8 milligrams after a poor anatomical response with faricimab. So a patient who was on Q12, Q16 weekly dosing of faricimab initially. So this is the patient initial evaluation. You can see quite a lot of fluid, intraretinal fluid, baseline CST of about 466. So this patient was loaded with faricimab initially. You can see after one dose, some reduction in macular fluid, further reduction, and then I was able to extend it to, we tried to extend quite quickly because patients in Hong Kong are frequently self-financing the drug, so there's no reimbursement for them, so the financial burden is quite substantial. So when I tried to extend to 16 weekly injection, unfortunately the fluid came back again quite rapidly, so I moved down back to 12 week, and then it started to respond again with good improvement in vision. So from 20/80 up to about 20/50 now. So this patient basically maintained on Q12 weekly injection despite having still a bit of fluid, but the patient said I'm happy with 12 weekly injection. But there was actually recurrence of fluid after the 7th injection. So and the fluid actually was getting worse despite having this is like 6 weeks after the 7th faricimab injection. So and then we got hold of Aflibercept 8 milligrams. So I asked the patient whether the patient wanted to try it, and the patient said yes. So I gave a dose of 8 milligrams and actually got a fair bit of response, 100 microns responses 4 weeks after the last dose of 8 milligrams. So I loaded the patient with second dose, and patient just came back for follow-up about 5 days ago, and actually did even better, another 30 micron reduction in macular thickness. So I'm now trying to extend the patient on 8 milligrams of Aflibercept. So this patient switched from faricimab to 8 milligrams Aflibercept with anatomical improvement, reduction in macular edema, and also a bit of subjective improvement in terms of visual improvement. So I think sustained disease control could be achieved with 8 milligrams Aflibercept in this patient with persistent DMO. With that, thank you very much. So please vote for us.
For a great case. I think we have excellent cases with different kind of spectrum presented here, and that is what we are looking forward to, especially once we have a new dose and of course molecule being older with us, how that is doing. Yes. So with this we go on to little bit of this thing, how if I have to ask a question to the audience and raising the hand, how many of you would be ready to switch from 2 to 8 milligram in your cases if you have situation the way it has been explained. So how many of you would do it once it is available? With raise of hands. That's great. That's really very encouraging. Yes. So with this, we move on to little panel discussion here. I think we're going to have, I'm going to just pose few questions to here first to Mike about the faster drying. And so what do you think as far as the faster drying is concerned, how does it help us, and in the long run, how it is going to be beneficial both for patient as well as for extending the time?
Yeah, so the faster drying is something that we see when we dive into the data on Aflibercept 8 milligrams, and it shows up very well within the data. If you take a step and look at sort of the overall improvement in central retinal thickness in the photon trial, you see these big humps in the first year, meaning that with 8 milligrams you get this recurrent edema. And it's not a function of the drug, it's a function of trying to extend patients to 12 and 16 weeks very quickly. That was the study design, to try to prove that extendability is not going to disadvantage patients with respect to visual acuity. But when you take a deep dive and you look at the most difficult to treat patients, those at the thickest quartile, they demonstrably dry much quicker and much better with 8 milligrams compared to 2 milligrams. We also find the same thing happens in age-related macular degeneration in the Pulsar trial. So you get this faster drying effect. Now, does that then translate into better visual acuity results? Well, it's not clear that it necessarily does, but what it does is it tells us very quickly that we have the disease under control. And it gives us that confidence that we can now start to extend, because disease control emboldens us to extend as it should and take advantage of that durability effect that we see over the course of 2 and 3 years.
I think great. That's really something I think we look forward to. And I have a question to Dr. Richard here. What specific clinical benefits you have observed, especially once you have switched from 2 to 8 milligram? So I think that is something everybody wants to know because this is going to be something new for all of us. Yes.
Yes, thank you. So we're just putting together our first audit, real-world audit results beyond 6 months now, and they're predominantly for neovascular AMD, but some for diabetic macular edema. And they are both for naive and switch patients. And what it's beginning to show is that particularly for those difficult to treat switch patients, we're maintaining visual acuity, maintaining subretinal fluid, but we're beginning to get longer retreatment intervals, perhaps by a few weeks or so. Now, I come back to Michael's talk, and Michael put up a really important slide, and that slide was that around about 3/4 of individuals, physicians, whether you're from Europe or Asia or the United States, feel that durability is the biggest unmet need at the moment. And actually it's really meaningful for our patients to get an extra 1 or 2 weeks or perhaps even longer. It means less visits, less burden on caregivers, less burden on the health system. So this is the main benefit that we're beginning to see. And I'm really pleased to be able to share that with you.
Thank you, Richard. I have a question to Tim Lai, especially I think what we saw, especially in the real life experience also here in the cases, that the switch was not like that you have given loading doses. So that was not done. So I think that was something very interesting. I think so. What's your take on that? Because it was sort of extending right from first injection, which was given after switch.
Yeah, very good question. So I think there are 2 groups of patients. The first group are those who were already stable on the previous treatment, for example, on 8 weekly or 10 weekly intervals with one of the agents. If you want to switch these patients, you don't need to load them, so you could directly extend to the previous treatment interval, and then even extend to like 12 or 16 weekly injections with Aflibercept 8 milligrams. But for those patients who responded not too well to other agents, for example, like my case, had Aflibercept, and then even at 6 weeks, it was actually showing worsening of the macular edema. In this case, I might consider loading them with the Aflibercept, 1 or 2 or 3 loading doses of 8 milligrams. And then if the patient responded well, then you can start to extend.
That's really nice and great. I think my last question was for all of you, I think about the switching. I think some of the cases were shown, especially where everything has been used. I think it was steroids as well, and all the whatever we have in our armamentarium at this time. So about that part, is it that you are seeing more benefits with the 8 milligram dose in such cases, because those are the real challenges we face all the time in our day-to-day practice? Yes, Mike.
Yeah, I think switching is definitely something to consider once this drug becomes available. You know, and it depends on what your goals are. For the example, the patients that I had, it was really extendability. For some of the other patients, it's trying to get improved drying, and perhaps with that, improved visual acuity. So it depends on the patients. Switching is always a little bit of a gamble, because switching doesn't always work. Because, you know, we know that despite whatever drug we have or subsequently ever will have, there will be patients that won't dry completely, and we'll always be treating them fairly aggressively. But this drug does work well with switching. Keep in mind what your goals are, and look and try to do things very prudently when you do make the switch.
Yes, Richard, what's your take on this? So,
look,
yes.
we're now practicing in a really fortunate time. Our patients have a number of different agents that can be used with longer durability, and a couple of things that come out from the case I showed. Difficult cases to treat are often difficult with whichever agent you treat. But what this gives us is another opportunity to try another medication. Now, to the point of switching, what I really like about the Photon and the Pulsar study, extension studies, we've actually got an inbuilt switch study. So upgrading from 2 milligrams to 8 milligrams, we can see the results of that. So that gives us confidence of what we're doing with that particular molecule. And at the moment, we haven't got so many switch therapies out there that we can use high-level data from. So, yeah.
Yes, Tim, your take on
Well,
this?
I think both speakers made very good points. And additional point is that you're treating DME patient. It's a systemic disease. No matter how many injections you are giving, they still need to control their systemic condition. So I would definitely tell the patients to control their diabetes, control their blood pressure and lipid and renal functions, because we are only treating the eye. So the physician needs to take care of the whole body. And in Hong Kong, we are quite fortunate. We've got quite a good healthcare system, and these patients, a lot of times, the eyes are the warning sign for them. So after giving some injections, a lot of them actually optimize their diabetes, and we can actually stop the injections to the eye.
I think we'll have one question from Dishant, and then move on. Yeah.
Thank you for the wonderful talks. Well, what did your US and UK perspective? For the US perspective, just for giving us an idea, what is the cost differential between 8 milligram and 2 milligram? And is it bang for buck if you get 50% extension, kind of, you know, from very bang to buck? And the second thing is that now that you're going to have a biosimilar for 2 milligram, does that really change your decision paradigm? And from Richard and from Shobha, I worked in the NHS as well. Does that change your drug of choice? So has NICE kind of got a guideline now on which molecule you should go with first, or is it yet left to every individual trust or doctor to choose? And how do you make that choice? Because if 8 milligram gives you better drying and better extension, then that should be the drug of choice. So has that become the #1 drug, and has 2 milligram been renegated, and all biosimilars been renegated, and Avastin, which sometimes is available? So how is, because they're two different health economics, so just the US perspective, because India is a mixture of both. We have a lot of free clinics, and then of course we have a lot of private practice. just to get a perspective as to how you're choosing your drug.
Yeah. So really good question. Drug prices vary dramatically throughout the world, not just in terms of absolute prices, but in terms of relative prices, as you well know. In the U.S., our wholesale price of 2 milligrams is $1,850. Our wholesale price for 8 milligrams is 2,600 and a little bit. Now, your question of, well, 50% extension, et cetera, it's about that. That was the way it was priced by Regeneron, with the thought that they were going to get fewer injections, and so the total dollar expenditure would be approximately equal on the drug basis based on fewer injections and greater durability. So that's how they priced it within the US. The second question was the biosimilars. And we have 5 biosimilars for Aflibercept approved in the United States, only one currently available to us, that's the Amgen one. It is priced at 90% of the price of the 2 milligram drug. So surprisingly high, and I think that, I can see by you raising your eyebrows, it's like, why did they price it that high? And the answer is, I don't know. I think what it will do is it will discourage people from making the shift from a drug that we've used for 13 years and are very comfortable with to another drug that, ostensibly should be the same, but as we know with biosimilars, and certainly in India, you guys have more experience than anybody does, it's not always the same with respect to safety, et cetera. So it's been a slow uptake at 90%.
Thank you, Mike. I think you answered it very well as clarified so many things. I think with this, I come to the summary of this part of session here. I think we have a great molecule here, and we have seen all faster drying, durability, what we look for, and that is what our unmet need is. And that is what has been very nicely shown in all the presentation here, as well as from the photon trial. And what also impressed me was that sawtooth and the straight line, I think, which to me is something, anything sawtooth, we don't really feel that comfortable. If we get that kind of a response, I think we're going to be all benefiting our patients in the long run. And the issue of safety always is there, and there are no additional safety concerns at all with 8 milligrams, so that gives us another confidence to use this compound. I think the way everything looks like at this stage for us, from all the presentation and the trial results, I think we are ready to go. So that's what I can say. Thank you very much all for presenting excellent cases as well as presentation. Thanks.
Thank you, Dr. Dogra. So we will move on to the Vision Academy and go through some hot topics in ophthalmology. We have only half an hour, so we'll be pretty quick in this part. So the financial disclosures haven't changed over the last few minutes, so they remain. So the Vision Academy is funded and facilitated by Bayer. It's a huge resource, a knowledge resource available for all of us. So in today's agenda, we will be going through a rapid fire presentations on hot topics, again with Richard and Timothy, and then we'll go through a panel discussion yet again. So a brief introduction about Vision Academy. So it is, the Academy is formed of an international group of 80 experts worldwide. And the main role of this is to build consensus guidance for managing challenging situations in our clinical practice, and also to deal with some controversial topics, and especially those with insufficient evidence in literature. So the Vision Academy has been ongoing for 10 years and significant number of outputs and activities. You can see 24 peer-reviewed publications, significant amount of citations, ongoing viewpoints and slide decks, podcast, videos, symposia. This is exactly one of them today. In APAO, we are having yet another symposium where Vision Academy is being presented. And it's a wealth of educational materials. For example, there are questions like, how do we deal with bilateral anti-VEGF treatments? How do we deal with RPE tear, etc.? You can read all this up in this Vision Academy website. There's continuing number of publications, things that we have in clinic that we've often struggled with, look up literature. We do not have anything much. So please, my biggest advice would be to check on these viewpoints. They are available in many languages as well. So this is the QR code by which you can get to the Vision Academy website, and also the link is provided. So I'll move straight on to expert guidance on particular topics. Thank you.
Shobha. It's really my pleasure to be part of the Visual Academy Steering Committee. And we're going to move on to, please note our financial disclosures. So I'm just moving on to the initial slides here. Here we are. So the first topic is expert guidance for the use of new regimens with extended injection visit interval. This is really important given the second generation of longer acting therapies. And remember, this is drug agnostic, whichever therapy that we're talking about. So it's very clear that the first generations were very good at improving visual acuity, but often required monthly or bi-monthly treatment. And obviously, the recent researchers try to extend these intervals with second generation medications. So just to give an outline of the Visual Academy publication, the objective was to provide guidance on how best to manage these regular and more extended intervals. And it was done really through a participant survey, asking how comfortable physicians were to extend. And the preliminary opinion was that extended retreatment intervals are suitable for patients who respond well in particular. And of course, surveillance is required. Let's just dive into that a little bit deeper. So the methodology included the expert opinions and advice from the Vision Academy Steering Committee members. And really they were asked three things. What was the longest injection interval comfortable? How frequently would you want to monitor in between, if at all? And if it reactivated the disease, what would be the reduction? And these preliminary recommendations were presented through a live meeting in 2025. So base case scenario for diabetic macular edema I'm presenting here is that this is the only affected eye that was mentioned or being treated. And the longest comfortable retreatment interval was around 16 to 24 weeks, often driven by the data but practicality of monitoring the second eye. And the frequency of surveillance, if required, was around 12 to 16 weeks. And again, this was driven because of retinal non-perfusion or retinopathy grade status, never forgetting that we need to monitor this at the same time. And a reduction in retreatment intervals should be between 2 and 4 weeks if there was reactivation. So let's have a little look at the situation for neovascular AMD. And the base case scenario was treating the only effective eye. And very similar results here. So the longest comfortable retreatment interval that most physicians recommend was between 16 and 24 weeks. But frequent surveillance between 12 and 16 weeks was recommended, particularly for reactivation in those difficult treat ones, but also to monitor the other eye in case that developed neovascular AMD. And this was the case across all macular neovascularization subtypes. With growing experience, perhaps longer treatment intervals could be extended further. So in summary, this publication provided background with the Vision Academy expert opinion on the consensus recommendation. And until longer-term real-world evidence becomes available, the Vision Academy Committee practical recommendations will be informed by these expert opinions. So I'm going to move on, if I may, Shobha, to the second Academy recommendation of the development of a new concept called time in range standardization of a measurement of clinical endpoints in retinal diseases. Now let me explain that a little bit more. So that in clinical trials and clinical practice, we tend to focus on the absolute visual acuity as an endpoint, perhaps non-inferiority, to enable cost-effective and efficacy outcomes to be demonstrated. But it doesn't take account of those fluctuations in between. So this new concept of the time in range may well be important, and that is something that is already used in other areas such as diabetology. So let me explain that a little bit more. So perhaps if we took best corrected visual acuity, instead of using that final endpoint, we looked at the curve over time of what happened of visual acuity. Now, this is not an entirely new concept. Statistically, we can use area under the curve analyses, which do look at effectively over time what is happening with the visual acuity. But there are some disadvantages of that, and time itself may be a better outcome. And this slide demonstrates it really nicely. So look on the left-hand side here, we have the visual acuity going up and down in green, where it's more of a flattened curve on the right-hand side. Both scenarios have the same visual acuity starting and finishing point. Both have a similar area under curve, but the one on the right-hand side has more time in range. And perhaps this is more meaningful for our patients having visual acuity. And of course, this are perhaps not just an important concept in retinal diseases, but could be applied and has been applied to other therapeutic areas, such as the phasing of intraocular pressure over time in glaucoma, and perhaps in uveitic conditions where the control of inflammation can be plotted. So what are the Visual Academy recommendations? Well, first of all, we need to understand the limitations of reporting a single one-time endpoint. We need to consider whether not just best corrected visual acuity time in range is important, but perhaps there are other parameters which are important, such as central retinal thickness or even quality of life outcomes. So in summary, this could be crucial information in both clinical trial primary outcomes, but also clinical outcomes as well. And we may want to consider this not just for best corrected visual acuity, but also for other important outcomes as well. I'd like to thank you for your attention.
So the third topic I'm going to talk about is the impact of anti-VEGF injection on IOP and the optic nerve. So this is another work stream that we've worked on in the Vision Academy. So just some background. So acute short-term elevation of IOP can occur in some patients, and in terms of the IOP increase, what is defined as ocular hypertension? So basically any IOP above 21 to 25 or 10 to 5 millimeters mercury above the baseline for at least 2 consecutive visits, these might be considered, but the variation varies in the literature. So because of the increased IOP, there might be some chances that, especially in patients with glaucoma, that they can have progression, or even those without any pre-existing glaucoma, they can develop glaucoma. So nowadays we have agents which has actually higher injection volumes. For example, 8 milligrams, Aflibercept is 0.07 mil. But if you look at the GA drugs used in the States, they are actually 0.1 mil of injection. So you really need some guidance on how to deal with these injections of higher volumes. So just to recap, sustained IOP elevation greater than 21 to 25 millimeters mercury, or 5 to 10 millimeters mercury above baseline for at least 2 consecutive visits. So in theory, this can damage the optic nerve. So it's been shown that sustained IOP rise can cause RNFL, retinal fiber layer, and optic nerve damage. And in particular, patients with pre-existing glaucoma, they already have a thinning of the retinal fiber layer, and therefore repeated injections sometimes might cause some damage. So how do we deal with these cases? So IOP can be medically controlled. We can use anti-glaucomatous medication, or you also do laser trabeculoplasty. And in previous filtering procedure, these patients sometimes they have spikes. But sustained RPE elevation, if you look at the clinical trial data, it's actually quite rare, and you can actually, if you just use anti-VEGF injection, it's quite rare and can be managed quite well topically. How about the correlation between the anti-VEGF injections and reduction in retinal fiber layer thickness? If you look at the recent meta-analysis, actually, if you, the clinical relevance of these are actually not too clear. So in a small study of 16 patients with glaucoma who are receiving continuous anti-VEGF injections, they found that the retinal fiber layer thickness was actually not significantly different compared with baseline. So this suggests that patients with glaucoma who are having anti-VEGF injections, provided their IOP is well controlled, they might actually not be at risk of having further damage to the retinal nerve fiber layer compared with those without glaucoma. So what's the recommendations from the Vision Academy? So these are patients, in all patient group, they should be monitored if they have any sustained elevation, and consider treating these patients with a glaucoma specialist. So these are the the recommendation for patients without any history of glaucoma. So basically, monitor their IOP, assess the optic disc with biomicroscopy, OCT, perform regularly. So in addition, you should consider doing baseline static Humphrey perimetry, doing the disc OCT and looking at the retina fiber layer imaging baseline, and then every 8 to 12 months. For intervention, if they actually had some increase in IOP, then of course you can consult your glaucoma specialist friend using one of these agents: beta blocker, carbonate anhydrase inhibitor, alpha agonist, or prostaglandin analogs. And also consider, if you don't want to have these IOP spikes so frequently, then consider extending the treatment interval or using some drugs which can actually extend your treatment interval. In cases where it's more complex, they have sustained IOP elevation, and also other conditions like RV or severe diabetic retinopathy, because these patients already had their optic nerve impaired. So you should actually monitor these patients with a glaucoma specialist. Also, patients with pre-existing glaucoma, again, consult your glaucoma friend. Gonioscopy can be performed, especially in RV and severe diabetic retinopathy, just to exclude any new vessels in the angle. And then you can monitor these carefully and consider even prophylactic IOP treatment before the injection. And if they are very high spike, consider corneal paracentesis. So just to summarize, the Vision Academy developed some recommendations on the monitoring and treating IOP elevations for patients requiring frequent anti-VEGF injection. So patients already with some transient amaurosis should receive prophylactic pre-treatment for lowering their IOP. The risk of these actually is very low, but you should still monitor them and consider monitoring together with a glaucoma specialist. So just to recap, you can find the guidelines in the Vision Academy website, and this is the QR code for it. Thank you.
Thank you. So now we'll go on to a panel discussion again. It should be interactive, and please submit your questions to us as well. So
am I audible?
yeah.
Yeah. Dr. Timothy, I have one question. What I understand from your presentation, I think we have two concerns regarding when we're talking about the control of IOP. One is concerned with the disease per se, where the patient has neovascularization. And second, what I understand is the acute rise in IOP will be injecting intravitreal. So I think we have to deal with both the things. So if it's a neovasculator, then it has to be a regular check in IOP, and whenever we are injecting intravitreal, that is altogether different, because we are inducing it at the time of procedure, which may require paracentesis. Is that what I gather
Yeah,
from your presentation?
thank you for your question. So this work stream is actually looking at sustained IOP, so it's more like a long-term increase. So at least 2 visits of IOP above 25 or 5 to 10 millimeters mercury above the baseline. So we're not dealing with the acute post-injection IOP. Those, of course, you should monitor carefully. For example, after injection, you might consider doing finger counting, for the patient, just make sure the optic disc is perfused after injection. So, of course, every injection, in our centers, we always check the IOP before the injection, and sometimes you also do it after the injection as well. But I think just by checking the perfusion of the optic disc is sufficient, and usually get increase there are some very good study in the literature. After 1 or 5 minutes, most of the cases will have the IOP reduced back to actually go quite a good level, and almost all cases within an hour they would actually go down to the baseline level. And I think Michael was in Hong Kong and he gave a very good case scenario as well of doing AC paracentesis. Maybe Michael, you want to comment on that?
Sure. So I think, you know, and to your point, it's the question that we don't have answered very well is what are the effects of repeated intravitreal injections, meaning the spikes. Does that accumulate over time? And the answer is we don't really know. There is mixed data regarding do we get nerve fiber layer thinning over time in either non-glaucoma or glaucomatous patients. I did a study a few years ago in our patients. I had 34 patients with glaucoma that were getting intravitreal injections in one eye, and that was with 0.05 mils. And over the course of a year, there was no significant difference in nerve fiber layer thickness or visual field changes in the treated versus the untreated eye, but treated meaning the injected eye. But 2 of the patients had irreversible rise in intraocular pressure. So we can't ignore the fact that there are some patients who really develop an anti-VEGF related glaucoma. And those, of course, we need to watch for. You know, can you get increased rises with the newer agents or higher volumes? And the answer is yes. And so, you know, we have to be cognizant of what happens immediately after the patient gets injected. Some of my physicians, colleagues in the United States, say that in glaucoma patients, they will do a paracentesis before an injection in a patient with glaucoma, regardless of the volume being injected. And they just feel that they're going to mitigate any transient increase in pressure and its effect on the nerve fiber layer.
Better safety as far as if we just do paracentesis.
Yeah, it's a aggressive approach, but there is a yeah, there's certainly a logic to it. I don't say the majority of people do that, but some will do that. Others will go ahead and give, you know, prophylactic beta blockers or other pressure lowering agents, and some will either do pre-injection gentle massage to increase the pressure slightly, you know, not a big spike, but increase the pressure slightly, soften the eye, and then do the injection. So all of those are reasonable strategies.
I would also recommend that you all can read up the Paris et al. Paper that was just published comparing the IOP rise in the acute phase as well as sustained IOP rise, which means it's like a few seconds, 5 minutes, and 15 minutes. And invariably, irrespective of what dose you inject, there is it's beyond physiology, so there will be a rise if you take your IOP measurement just in minutes after the operations shift.
Depends upon if the patient gets recurrent, then I'm probably because of electrosimility, the more volume is there, so
yeah.
patient may be able to tolerate more.
So
it depends on how many you've injected and what's the patient condition is.
Actually, we all practice Tim's way of looking at the optic disc. You know, if the patient has vision after injection, we are pretty safe. We won't rush into a paracentesis, but maybe as you said, in very rare cases of glaucoma where you feel that the blackout is more than anticipated, then in the next round you can think about it. Just now coming back to the discussion, I would just want to iterate that I was involved in a study here previously looking at anti-VEGF in diabetic macular edema across 10 retinal centers in India. The average injections given at that time was 2 injections and with no vision gains. Now, Richard and I have done several real-world studies in the UK where the drug is free, of course, for everyone. There we give an average of approximately 7 injections, and the weight and the vision gain is also about 7 letters. So to answer the recent question that was asked about anti-VEGF, Aflibercept 2 milligram versus Aflibercept 8 milligram, in UK, the price is the same for 2 milligram and 8 milligram. So if the price is the same, and given that in Photon, only 10% needed 8 weekly injections, my question is, can in India, we manage patients with diabetic macular edema by giving 12 weekly injections fixed? If they do not turn up, they have at least a 16 and a 20-week dosing available for them to catch up. So can I ask the audience, can I ask the speakers here, Tim first?
Well, in Hong Kong, we are also having the same pricing for 8 milligrams and 2 milligrams, and that's why a lot of 2 milligrams patients are switching to 8 milligrams, because if you look at the clinical data, it's superior in terms of durability. So it's a no-brainer. The patients are getting better value for money.
And sustainable as well.
Exactly.
Yeah. What about you, Richard, if you were to implement something in India to help patients gain their visual acuity as well?
Look, I think it's a very reasonable approach, if there's capacity and financial strains, to look at that photon data about Q12 or Q16 in the long term, because actually, by far the majority of patients gained, very few lost vision over time, and it's a very pragmatic way of doing things. And perhaps if we're giving 2 or 3 or perhaps 4 injections in a scheduled way in the long term, we can achieve these results. And in diabetic macular edema, I'm slightly less concerned about individuals not being monitored in between their visits because of the rate of accumulation and the apparent lack of damage, if you like, if there is a reaccumulation. Perhaps that's slightly different in neovascular AMD. Let's remember from the clinical trials, each of these patients was seen, at least initially, on a monthly basis to be able to capture any difficulties that occurred. So I think it's a very pragmatic way, load with 3 and then straight out to 12 or perhaps even 16 weekly.
Thank you, Richard. What about Michael?
So, Shobha, I like the way you framed the question of every 12 weeks in diabetic macular edema, because we can answer that question fairly well from the first year of the Photon trial. When you look at the number of patients who were randomized at baseline to Q12 week therapy after 3 monthly injections, and then were maintained on Q12 week through the first year, which is really sort of what you're talking about, that was about 89%. And so the answer is, it's using that strategy, it gives you a 9 out of 10 chance that it's going to be successful.
Dr. Dogra, would you change your practice and start this if you get the 8 milligram?
Definitely. I think what has really been shown here in the symposium, just giving 1 injection and extending that, I think that's going to be something which is very important for us. And if the way the trial has shown, if it is going to show us that almost like close to maybe 80% are going to have 3 monthly injections, so we come to the same. So that part is quite exciting to me at least, and I'm sure it will be for all of us. And if the pricing gets to the same, I think we are really looking forward to this great molecule.
Especially when Michael said the biosimilar cost is almost as high, and if you can get 2 milligram cost equal to 8 milligram Aflibercept, it will be a winner for India, I think. The other question I have is about this time in range, Richard. That seems to be a really useful one, which we had never done. All our results, trial results, audit results are all at the end of 12 months or 24 months. So do you think you'll take that to practice?
Yes, I think we should start looking at this both in clinical trials as secondary analyses, but also in our clinical practice in large data sets, such as the NOD data set. FRB, for example, could begin to look at this. And I think why I really like it is it's because it's a patient-friendly metric. You know, I absolutely understand why we have to look at the efficacy endpoints for the calculation of efficacy and health economics, but actually we should really move towards patient-friendly time in range. And I would much prefer to see my patients have a sustained, good visual acuity over time rather than a rapid increase and a drop-off and then perhaps an increase towards the end.
So from that question, in India, they do refraction, as I understand. They do refraction at every clinical visit. So, Tim, would you be reliant on visual acuity in such circumstances than rush with CST change or use photon criteria about vision change and OCT increase in CST?
It's still a bit dependent on the patients that whether they are in a very good condition or not, and also depends on the your technician. Sometimes they are having a lot of workload, so they might rush through the refraction, and the VA might not be actually the best indication. So for me, I look at both, but I rely a bit more on the OCT findings.
Yeah, we do in the UK as well. We are very reliant on OCT because our visual acuities are often measured in difficult circumstances. So Richard, would you rely on OCT? And we just said that patients could just go on a 12-weekly fixed. So for example, if a patient comes 12 weeks later and there is fluid at that time, when it was once dry, do you change your regimen, or do you think Photon has told us we can still keep them on 12 weekly?
Look, I think visual acuity and central retinal thickness have two different functions. Visual acuity, because of the fluctuations and the issues that Tim mentioned, is a really good metric for retrospectively looking at cohorts of patients because those fluctuations begin to be balanced out. But on a day-to-day basis, it's the central retinal thickness. Remember, our OCTs are highly reproducible to within 4 or 6 microns of rescan, is really what's driving my practice. So what would I do if there is a degree of reaccumulation over the time? Look, I don't usually jump to make a switch at one individual change, particularly if the symptoms and visual acuity have maintained the same. I would give another treatment and see if that's a sustained pattern. But of course, if there were symptoms, a drop-off in visual acuity, as we've seen in Photon, 10 letters, perhaps 15 letters, I would then begin to think it's now time to change. Time to change medications is a controversial topic. So we can change because of lack of efficacy, and there are published guidance or expert opinion on that. That usually occurs within 3 or perhaps 6 months. And changing medications because of durability normally occurs within perhaps 9 to 12 months when we can understand what our new goals are for our patients in terms of durability. That 12 weeks is really our new goal, or perhaps even longer now.
So Michael, yes, continue.
So I really like the concept of the time and range. As with many things, the devil's in the data. You know, and my son-in-law is a pediatric endocrinologist at the Barbara Davis Center at the University of Colorado. All he does is type 1 diabetes research. And so he lives in the world of time and range, especially because he works with technology, continuous glucose monitors, and artificial pancreas. The challenge we have is how often do we get our data? Monthly, if we're lucky, from studies. Every 3 months we see patients. He gets data every 2 minutes. And so time and range to him means is much more accurate analysis than what we get. So I think it's worth pursuing, and somewhere along the way we need to develop a home monitoring device that measures visual acuity.
Yeah.
And that's going to give us time and range to know that we're not getting those bad spikes that we think we might be getting, and that's the way we're going to be able to tell what kind of how well are we helping patients functionally.
Thank you, Michael. So I have another question. So we have this threat of 2 milligram biosimilar to start patients on 2 milligram biosimilar first and then to switch to 8 milligram. Or we can also, like Richard, start patients on 8 milligrams straight away. So that's the variation in practice we have in the UK at present, and this may change over time as well. Michael, I understand that's the case in the US as well, step therapy. So which patients would you start on 8 milligram and which patient do you want step on, or is there any any such categorization?
Yeah, and you're right, Shobha. It varies actually based on insurance companies. You know, some insurance companies will require step therapies, and other ones say use whatever you want. So, you know, given the data that's come out of Photon and Pulsar, I tend to go with 8 milligrams first for all of my treatment-naive patients, period. Because I think when we look at the rapid drying effect and then the durability, it gives us a nice, you know, clinical picture that we can get patients dry and then extend them quickly. Now, that being said, is there any disadvantage to step therapy on the assumption that the 2 milligram is not going to dry or the biosimilar is not going to dry as quickly, which we expect in some patients? I think we can get some solace from DRCRnet protocol AC that suggested that even though in those patients, they used bevacizumab as their first-line therapy that were relatively undertreated, still can then benefit from switching to a more potent agent when they've demonstrated that they're not getting the clinical effect they want. So I'm going to extrapolate and say we can probably get that in diabetic patients, even if we go from a biosimilar to 8 milligrams. We probably haven't lost a whole lot, if that's the case.
Dr. Dogra, once you get your 8 milligram, would you change your practice in terms of biosimilars being available?
I think biosimilar for Aflibercept is not available at this time in India. So for me, what also is exciting here is that mostly we are having this 3 loading dose concept for most of our anti-VEGFs. And that is what is happening here. I think that is exciting. That if we get similar price and we give 3 loading doses rather than going on to 5, we are already starting at a very kind of a different this thing, as well as we have an advantage. So patient is not going to visit that much and then go on to treat and extend. So that itself gives confidence to start 8 milligram in treatment-naive patients, and definitely I think that will be something we are looking forward to.
And what about monitoring the diabetic retinopathy?
As far as the, I think these days mostly apart from other things, I think for us, as far as the monitoring for the treatment is concerned, most important remains OCT, as already highlighted. And of course, visual acuity we always kind of look at. So many times we have stable visual acuity. Down the line, we have treated a patient and maybe OCT is showing something going up. We tend to kind of watch such patients. So I think OCT gives us a that way a advantage always, but not all the time that we want to just treat something which is coming up if the vision is stable still, especially in where we got very good visual acuity gain. Yes.
One last question for everyone. A patient with PDR with diabetic macular edema, how would you manage? Tim?
I would do combination therapy, first inject anti-VEGF and then do the PRP.
Richard?
Yes, same. I think the evidence for retinal laser is irrefutable and also can potentially be a permanent treatment. And my fear is the loss of patients to follow-up. So we do have a significant amount of loss to follow-up in diabetic patients within the UK, and perhaps that's larger in other jurisdictions. So that would be my first concern. But like Tim, I would aim for dual therapy, but I wouldn't undertreat the retinopathy.
Michael?
And I'm probably a little bit more liberal than my other two colleagues in terms of treating with anti-VEGF monotherapy, but I have exactly those same concerns that Richard just talked about, and that is loss to follow-up and then having disastrous neovascularization as a result. So I tend to spend a little bit more time with patients talking about the need for follow-up and the give and take with respect to peripheral vision loss, at least acutely with PRP, versus maintaining that over a period of time with anti-VEGF monotherapy. But I really try to restrict anti-VEGF monotherapy to patients who I feel are very compliant. But they're and we all have these patients. You see them when they come in the first day. You know this is a non-compliant patient. And those are the ones that I go to PRP very quickly on.
Thank you.
Yeah, I think we do the same. We give anti-VEGF and start PRP. We don't give monotherapy for proliferative diabetic retinopathy here, but most of the time we start same day PRP also, so that the patient knows that he has to come back for other sessions. So, and as well as we explain that this is not one injection. If there is a diabetic macular edema, then they're going to have same loading dose concept also that they have to remember. Otherwise, if we see simple proliferative diabetic retinopathy and macular edema is not there, and we see a hemorrhage or something, there maybe we just give one injection and do PRP, that's it. So that is different from the other one.
Thank you. And any questions from the floor? Yes?
I wanted to understand what would be in which subset of the patients you would consider Eylea 8 milligram vis-a-vis brocilizumab. Because then the drying of the macula will be more or less same with both the drugs, and vis-a-vis when you're comparing it with faricimab. Which subset of patients for all these three categories?
So I'll start. You know, brolucizumab is very little use in the United States, and that was the safety concern. I understand of all the countries I've traveled to, probably more use in India than anywhere else in the world. And I keep asking my Indian colleagues, do you not see inflammation? And the answer is generally no. But in the United States, there's very little brolucizumab that's being used. With respect to Eylea versus faricimab, both have very good drying effects and very rapid drying effects. I think both are excellent choices at the beginning.
Maybe I can a little bit answer this. The way we are using brolucizumab here in this country is totally PRN. Nobody is given loading doses. So it is only PRN, we give injection, then we wait for another one. So the question is, probably it is an unending process. So that is where we are, because we don't know what is the end point. So that is what we have to remember. It's a good drug, and no question. Probably we do get here also whatever inflammation and other things, but not that much. But that is what the problem with the drug is, that we have to wait and give another injection on PRN basis. So that will, in the long run, be more perhaps doing kind of more damage to the photoreceptors and others, because and we have no endpoint. So that is what is happening. Mostly I see across, even most presentation, where we hear all the experiences from across India. Nobody is giving loading dose in the diabetic macular edema.
Thank you. So it's 1 o'clock. We'll close the symposium. Oh, you have one more question? Yes.
Thank you all so much for a wonderful, educative early afternoon. I have a little concern away from diabetes is for vein occlusions. What are your suggestions for 8 milligram? How does it? Because we are using our 2 milligrams and we are getting very good results. So if it's prudent to ask.
Yeah, of course, yeah. We can ask anything, and then we can talk off-label and say anything, you know. But you know, the Quasar studies showed very good response and good extendability with 8 milligrams, and it really showed that you can go up to 8 weeks quite consistently and safely. So I think, because as you well know, vein occlusions are a very, very treatment-dependent disease because of the very high VEGF loads. And so I think of all the diseases that we treat, I think vein occlusions are the ones that makes the most sense to go to 8 milligrams, because they're the hardest to extend, and 8 milligrams looks, according to Quasar, that that's going to be achievable. When we get it approved, of course, whenever that's going to be.
So thank you, and thank you to Bayer for arranging the symposium.